Hey, everybody. Welcome to class 9. So welcome if you're watching live or you are watching in the replay. Everyone is welcome at this class, whether you're expecting a baby, you work with people expecting a baby, you're curious about labor and birth. No bots are welcome, though. Yesterday during our live class, there were some kind of crazy bots going on in the live chat, so they are not welcome. But welcome to all of you guys. I love the pre-class chatter. I see a question I'm going to answer, and I want to give a shout out to some news. Let's see. Christy shared that she has that of her twins, baby A is head down, which is great news. Definitely celebrating you, Christy. Well, that is just awesome news. I am drinking my tea like you guys. I see some other tea drinkers in. Welcome to Kayla and Elizabeth and Christy and other Kayla and Melissa and Bridget. And we got a good group. We got a good group so far. And Amy, welcome guys. How was our day? So let's see. Let's do a little check-in question of the day. Tell me, what are you most looking forward to? Here's the question. Of the classes that remain, are you most looking forward to pushing, cesarean, the baby, our pain management class, or the quiz, which I haven't even mentioned at all, that class 14 is a quiz. So it's really fun. 14 is where we test our knowledge. We have lots of fun. It's super casual. Not that this isn't casual, but it's a great time. Last night's class was really busy. I mean, in the replay, there were a lot of people watching replay. So welcome new replay viewers. If you've missed any of the prior classes that you want to catch up on, you can buy all of the recordings, $19 for the whole set, and the link is below. Hello to new faces. I see Esther new into the chat. Esther and Sammy and Johnny. Let's see. Okay. Oh, we've got some pushing, pain management, C-section. Good. Melissa says, I'm here for the chat. I love it. Yes, we have a quiz on 14. So awesome. And the baby. Yes, Bridget, thank you. Did I mention the baby? I don't know if I mentioned that one as a class, but yes. In the class on the baby, we talk about all those it's not just about the baby, it's about the placenta, about the ring of fire, about vacuums and forceps and skin to skin and newborn procedures and all that kind of stuff. So that's a good class too. Tomorrow for pushing, I think I mentioned, I did mention it. Okay. Thank you, Diana. Tomorrow for the pushing class, I know I mentioned that I reroute. I move all of my filming equipment over to another area of my house, and where we have a bed, my older daughter's bed, and who's in college. And then I, sort of rework. So it takes a little time to get ready for pushing, but it's definitely worth it. Which my tip for tomorrow is, make sure if you are watching this, which you're going to be, I don't know why I said if you're watching it, when you're watching it, watch in a place where you can hopefully practice the pushing positions with me. So whether that's a couch or a bed or something like that. So kind of be ready with your strategy for where you're watching it. I don't know where you guys are watching it right now. Are you walking through a subway station or sitting on your couch right now? That's the beauty of a virtual class on YouTube. You could be anywhere. Okay, let me, first of all, induction day 2. As you guys know, today we're covering the how of induction. So we're covering the why induction is done. So we will cover that. We're also going to talk about hydrotherapy in labor, which is a really great tool. We won't practice hydrotherapy. At least I won't practice hydrotherapy while we're on the screen, but we will talk about it. And I forgot to mention, I sent it to our 2 other pieces of news, and then I'm going to get into those questions that are already in the comments. The other 2 pieces of news, one, the donation goodies from the Buy Me a Coffee donations are going out tonight before my head hits the pillow. They are all ready to go. I just have to grab all the email addresses and send them out. So keep a look for them tonight or tomorrow. If you go to bed before I get them out, because I am on the West Coast. And if you're not, you might be in bed. And then I have finally announced the mindset course. So the mindset course that you guys showed interest in, it now has an official name. It has a date, 2 dates we're offering it, and it has a format. I didn't want to just throw something together. I wanted to make sure that I was going to teach a course that you could leave with actionable skills, and just that I felt very comfortable that boom, from the beginning of the course to the end of the course, that you were going to see a difference. And that's what we have. So it's going to be, the first offering is December 15th. It's going to start 1 hour earlier. So it's the 15th day. And I'm also offering it January 26th at 8:00 p.m. Eastern time. So you can find all the information there. And always you can email me, and let me change my page numbers too. Awesome. Okay, let's look at these questions before we jump in. Jenna says, if you are medically induced for your first labor, will your body act more like a first timer or a second timer with the next baby? Totally second timer, Jenna. Totally second timer. So that's a great question. But your body was jump started into labor. So you labored. So you will be more like a second timer. Great question. Okay. And I know there was at least one more. Scrolling. I love how everybody, okay, good. Pain management, pushing. Okay. Clarissa. I see a lot of sample birth plans that say no to Pitocin after birth. I thought it was given to speed up the placenta's birth. Is that also true, or is it just postpartum hemorrhaging? I actually saw your comment on YouTube today, and I meant to get back to it. So I'm sorry that I did not get back to it. So I am going to give you a super quick answer, and then we're going to talk about that more on the baby day. So yes, the Pitocin after birth is actually like a safety net for postpartum bleeding. It's a safety net, and we'll talk about more. It's not really to speed up the birth of the placenta. It's to prevent postpartum hemorrhage. And it's not a necessary thing. They do it preventatively. Yeah. Khalifa said, husband is taping today. Oh, I'm so interesting. Tapping today. I want to know what tapping is. I don't know. Maybe I should know. Hubby is tapping today. Sounds exciting. Okay. Maybe I missed a question. Oh yeah. Benefits of declining Pitocin. Yes. So if you don't mind, Clarissa, if you need an answer tonight, email me. But if not, we're going to go through that on the baby class, which is class 12. Class 12. Okay. And Anne, yes, I just changed my pages. Okay. Yeah, Jenna said she's so happy to hear that. Yeah. Oh, no. It looks like a bot. Okay. Again. Oh, husband is watching the class. I'm so dumb. I'm either dumb or like really behind on it. Welcome, husband. I love it. Now I feel like sometimes when I hear that new people are here, I get a little bit worried. Okay, awesome. Khalifa's laughing at me. I love it. Yes, it's another bot. Bots are back. You know, I was telling one of my kids at dinner last night said, what was that about the bots and on your class? And I was like, yeah, bots. Okay. we're not going to let them bother us. You guys know if you have a question for me, put the Q. Anne says, Alice, there is such a thing as tapping, and it is for mindset, ironically. Oh, yeah. Like I was thinking like tapping, you know, I know about that kind of tapping, like tapping on our, that's pretty awesome. Okay. Okay, guys, let's get our slides up. We're ready to go. And let me get into my, presentation mode for a second. Technical difficulty. Here we go. Here we go. Now we can do it. I got thrown off by the bots and the tapping. Oh my gosh. Why? There we go. Also, can you guys hear me okay? It is so cold in my office today that I have the space heater on. I usually turn it off, but it is freezing. Just let me know in the chat. So we're going to talk about a lot of, great, thank you, Kayla. We're going to talk about a lot of reasons for induction. We are going to cover the what is considered medically indicated induction. We're going to talk about what's called elective induction. And we're going to talk about kind of how sometimes it's confusing on which you are, what's recommended for you. So we're going to cover these different issues. And if you either experienced an induction with your first, with another baby, or if you have a provider that's already, working on an induction plan for you, this is a good, I want to know, oh, okay, seriously, let's just block that user. I mean, life challenges, we just have to roll with the punches. Just like in labor, we're going to get things that are going to come up and we're just going to have to figure out how to work through them. And we might have to put some things in timeout in labor. You never know. Okay. So what I want to start with are some sort of overarching questions that actually have been posed by the American College of OBGYNs when they are advising how OBs should talk to their patients and about induction, how OBs should make the decision on induction or not. So these are some overarching big questions, and then we're going to dive down into the nitty-gritty details. Okay, so I think you guys saw that first one. The first one is, are baby and parent healthier with the baby on the outside? So that's kind of like, if we have sort of a logic diagram of like, start at the top, ask this question. If the answer is yes, baby and parent are healthier with baby on the outside, then move on to the next step. If the answer is no, then our conversation we might want to stop our conversation there. Okay, so this is kind of the big overarching question. If this question is yes, if it's a definite, clear yes, then we need to talk about induction. The next question, oops, wrong way, which might surprise you guys, is what are my preferences for birth experience? So what are your preferences for your birth experience? So this might be something, oh my gosh, hold on. Now I need to have somebody set up as a like moderator, but I don't have anybody right now. So I'm just going to try to do my best. Okay. The next step, which I really appreciate this, is what are my preferences? So your preferences do matter in this. in some cases. So again, first of all, is baby healthier? That could be if that baby needs to come out for the health of both of them, both either baby or parent, then that's what the recommendation is going to be. If that's a no, but the provider is still recommending an induction, or it's unclear on whether or not the health is better. And that's really the gray area that we're going to talk about. That's confusing. And that is something that in that case, the preferences of parents actually matter. Okay. So what this is saying here, the American College of OBGYNs and the American College of Nurse Midwives are saying that your choice is important when it comes to a lot of the decisions on induction, especially where it is not clearly medically indicated. Okay. Awesome. Okay. I love it, Bridget. I guess the bots didn't know the class was free and they bought it. Oh my gosh. That was amazing. That was awesome. Okay, so your choice is important. Now, I put this on the slide word for word because I think it's that important. And it is something that doesn't always happen. So it's from the American College of OBGYNs. Again, this is the governing body, the advisory body for OBGYNs, okay? And they came out publicly that said a collaborative discussion with shared decision-making should take place with the pregnant woman. So they're saying before induction is recommended that this needs to happen. Now, I'm going to pause and I'm going to bring out the real deal here. This is sometimes not happening. I would say it's often not happening. And this is a frustrating thing as a childbirth educator. It's a frustrating thing for consumers that when you see governing bodies like ACOG make these clear statements and suggestions, and then we don't see it happen, practice happen, that's really frustrating. And that is something that I want you guys to have as a takeaway, that your opinion does matter. And these discussions should happen. And Melissa, thank you for saying this. That should happen with all decisions. All decisions should come from a place where you are given proper information so that you can make a decision on what's right for you and what you want for your baby. Doesn't always happen. And it's unfortunate. And this is a theme that I know I've mentioned before. We're going to mention again. But this is what they say. So, if you felt like the decision was made for you, if you have a provider that says, and we'll talk about reasons, but let's just make one up. I think that your baby is getting big, you're measuring big. I'm worried about you having a big baby. I suggest that you come in, don't come in tonight and get induced. So that's not shared decision-making. What that looks like what should look like is a provider saying, I have these concerns about the baby's measurements. And my recommendation is induction. Now, here would be the benefits that we would be looking for, and that's why I'm suggesting induction. Here are the risks that you might want to consider. And I would love to hear what your questions are and what your concerns are about that recommendation. And then it's like a back and forth, right? Let me know in the chat if, that second demonstration feels better to you. Or can you imagine how a decision made after that kind of conversation would be completely different than just, I'm worried about your baby getting too big. You should come in tonight to get induced, right? Yes. Okay. Anne says, love it. Yeah, it's so much better. It's so much better when you can have that collaborative discussion with your provider. And, providers, they're human, they make mistakes. And your provider might be one that's like, with a quick reminder, hey, this sounds like something maybe we could discuss, and they're like, oh, yeah, of course. Oh, sure. But if you don't, it could be if you don't make the effort, you don't get to have that discussion. Yes, open communication for sure. Yes. Jenna said, that was not the scenario when we discussed my first. Yeah. And that is very, very common, that it's usually, it is often just recommended. This is what we should do, done. And no options are given. Okay. So let's see. Patty said, this hasn't come up in pregnancy for me, but with past medical experiences, I don't think I've ever had a provider openly mention the risks of something. I always have to do the research and ask. So true, Patty. I see it myself in my own healthcare. I mean, I saw it with one of my kids, teenagers. I just watched the whole thing happen. And my teen was like, why didn't they ask me or say that was optional? And it's like, there's no discussion. It does help to have good support people. And if you aren't able to bring a support person, your partner, a doula, to those late in-person prenatal meetings, if you can have them on the phone so they can be prompting you, asking questions, part of the conversation, video call, absolutely do it, even if you feel stupid doing it. Absolutely. Yes. Jay said, this was my first, and this was what happened to me about everything I asked about. Ugh, so frustrating. And high five, Jay. That is so strong of you to change providers, because you know what? Changing providers is complicated. It is really complicated. Okay. Oh, Kirby has a question. Oh, I missed that question. Thank you. If the process of an induction is looking like the most terrifying thing ever, what alternatives do we have when it's not clearly medically indicated? Yes. Okay, Kirby, hold on to that question for a second, because let's talk through what's indicated, what's medically indicated, and what's not. And then I think that we'll get to that. Okay. But if we don't, will you remind me? But I think if we have some real examples, that's going to make more sense. Okay. So we all know that our choice should matter. Oops, I skipped right through medically indicated. I'm going to, let me see if I can make this a lot bigger. I don't like that. Let's put it this way. Okay. So I know I've kind of violated one of my PowerPoint slide rules by putting a lot of data on a slide, and my apologies. So I am going to also read it out, especially for those of you guys watching on your phone. So medically indicated inductions. So this is a list, and it is comprehensive. There might be one kind of like random condition that's very rare, and that sort of falls into that first one. So the first one, we're going to talk through each one, okay, real briefly. But these are the pretty cut and dry. Induction is needed, and usually induction is needed fairly quickly. Within the next several hours, we need to sort of get on with the process. So the first one is like a big catch-all for maybe specific conditions that are happening with baby or maternal health. So if there are any severe conditions that are happening, so that would be like a one-off situation. It's something that has to do with your own health, like a heart issue, like if you have some kind of, have a heart issue. I had a client that had epilepsy, severe epilepsy, and it was recommended that she was induced, just as an example. I don't think that is research-based, actually, if anyone here has epilepsy, and that was several years ago. But the next one, probably everybody has heard about, and that's preeclampsia. So preeclampsia is where the your blood pressure usually spikes. Your kidneys usually are not functioning properly. They aren't filtering our blood properly, and our liver starts not behaving, and it can come on suddenly and without any kind of prediction. So it is, it's one of those like out of the blue. And that's why, getting your blood pressure taken at every appointment, checking for protein in your urine, those are all signs that they're looking for that preeclampsia comes up. Just a couple other signs that I want to mention, if you haven't heard them, just keeping them in your mind, that if you had extreme swelling that came on quickly, if you see spots before your eyes, not floaters or something, but like spots in front of your eyes, or if you feel a right side pain, sharp pain like a knife, you would want to call your healthcare provider and let them know that you're experiencing any of these. Those are also signs of preeclampsia. And the only way that preeclampsia can be cured is to deliver the baby and the placenta. And then that usually resolves preeclampsia, but eclampsia can happen to people after they give birth. So they're still at risk. That was a lot of information. Okay. So if anybody watches Downton Abbey, I'm not going to spoiler alert if you haven't watched it, but a character that gave birth in the first season, I think, suffered from eclampsia. And anytime I watch some kind of birth on TV and I'm like, oh, as soon as she had the baby, she said something. I just looked at my husband. I was like, oh no, this is not looking good. So sad. Okay. The next one is, remember we talked about rupture of membranes, and the P is the premature rupture of membranes. So when your water breaks on its own, but there aren't any contractions, and you often a premature rupture of membranes sometimes happens before you're due, also like in those last final weeks. Yeah. So if you don't have any contractions, but your water breaks, you can develop an infection. And so really the best thing is to be induced. I will say a small disclaimer that if you are very early in your pregnancy, that you might be monitored and hospitalized and not induced, and basically hoping to keep the baby in for as long as possible. So that is a little bit of a difference. Kirby said, if you have all the symptoms except the blood pressure, can you have preeclampsia? That is a great question. And yes, you actually can. Some people don't present with all the symptoms, but that's one of the reasons why they take like the urinalysis protein. So that's a good question. I think I might be wrong about this, but I think the blood pressure is something if untreated or uninduced, that it would show up. It would end up going up, but it might not be one of the first. Great questions. I love this group. You guys ask the most awesome questions. Okay. Yes. So it really depends on, yes, Jay, but all of that depends on the timing of it all. Yeah. Because yes, your body does keep making amniotic fluid. So that is also a positive. But yeah. Okay. And the next one is called intrahepatic cholestasis of pregnancy. So ICP. So this is a maternal condition that has to do with the functioning of your liver, and it can cause increased risk of stillbirth. And it also kind of comes out of nowhere. And if untreated, that it can increase the rate of stillbirth. So that is medically indicated. The next one is a suspected big baby who is suspected at over 11 pounds. So not just a larger baby, but a macrosomic baby, a very large baby. And the hard thing with that one is we don't really know. And so how big a baby is, because ultrasounds at the end can be plus or minus about a pound off in either direction. So that's why they moved that actually to 11 pounds. So if the ultrasound says 11 pounds, if your fundal height is measuring big, then they might suggest a induction. Not all providers, I will say, but they might. Okay. Next one. Oh, let me stop. Okay. Anne says, for preeclampsia, if you have low blood pressure, would elevated but not super high blood pressure be an indicator? I don't know. So usually with preeclampsia, you have to have other signs. So you have to have elevated blood pressure and like protein in your urine, your liver panel is off. So it's not just the one factor, because the other thing that is with high blood pressure, you could have what they call gestational hypertension. And gestational hypertension is not medically indicated for induction. It is actually medically indicated to monitor. I hope that made sense. Did that make sense? Okay. Yes. Quick fluid for me. Bridget said, if you're suspected to have a big baby, why not do a C-section? Yeah, so big babies do come out and don't always have problems in labor. So problems being birthed. So the research says that the first suggestion for a suspected big baby over 11 pounds should be an induction. And if baby is making progress in the induction, then that's like, descending through the pelvis, through the station, then they aren't as concerned. Okay. Sammy Lynn said, I'm 36 and have 2 prolapses. Could that be why they were offering me to get my membrane swept at 37 weeks and 5 days? Tell me about, I need to know, sorry. I don't know enough about your situation with prolapses, what's prolapsing. But we're going to talk about age, and age is not, it's on there in blue because it is controversial, as in it's not clearly defined. Yes. Okay. Yes, that's right, Melissa. The idea is to keep the baby getting any bigger. Yeah. It's not suspected by evidence. Yeah. Elizabeth said they were wrong about my friend's baby. First baby, 11 pounds, 12 ounces. Wow. That's awesome. I love big babies. I mean, usually. Okay. Oh, hi, Quinn. Okay. Start at the beginning, but we will see you when you catch up. Jay said, my sister was 12 pounds. My mom had her vaginally. They had to break my sister's collarbones to get her out of my mom with no tearing. Is that normal? So, normal isn't the word I would use. I would say, does it happen? Yes, it does happen. Collarbones are very soft and are breakable if needed to be to get a baby out for a complication. So not normal, but not like a unicorn. It's something that happens. Now, your mom was in a neck brace. Do you mean your sister? Let me know, because yes. So the collarbone situation, it does happen, but there are some different positions that healthcare providers are know better now than they did probably when your sister was born, or someone's brother was born. Kayla's brother was born. So, there are other options. Yes. That we know better. Know better now. Know better, do better. Right. Okay. Interesting. I read an article. I feel like I know what article you're talking about, Patty, about women over 35 having better outcomes because of more attentive care. That just came out. Was that, Patty, did that come out like this week or something? I feel like I just saw that. Okay. Sammy said, bladder and rectal prolapse from first delivery and the use of forceps. Yeah, that's probably why that they are saying, hey, we could sweep your membranes to see if we can get things going. Yeah. Okay. Whew, so much good chatter and stories and sharing and in the chat right now. I love it. Okay, so we did suspected big baby. We talked a little bit about that, but the next one is IUGR. So that's intrauterine growth restriction. And what that is about is when the baby is not growing anymore. So, or what they can see or what they suspect is that baby is not growing, which usually is a issue with the placenta. So again, if we talk about, is baby healthier on the outside? Yes, right? The next one is when you are over 42 weeks past your due date. So this is a big, big one. We are going to talk about past due on its own. So I'm going to just kind of skip over that one, but just look that it's over 42 weeks. It's medically indicated. Okay, so that means you're 42 plus 1 or 2 or whatever. The next one, gestational diabetes that's not diet controlled. And that's sort of not always considered medically indicated, but in some places, some providers do. Then we've got twins that are over 38 weeks gestationally. Some providers choose to induce twins after the 38th week. And the next one is a BMI over 30, which also I have seen over 40. So body mass index over 30 or 40. So that's also kind of not everybody is treating it that way. And then we're going to talk about age, but over 35 in some providers, they consider that a reason for a medically indicated induction. Okay. Let's talk about elective induction. Let me just check and see if I don't have any questions. Okay. Elective induction. So these are the common reasons for an elective induction. This is not every reason, but these are the common reasons. So the 39-week induction, and that is the ARRIVE trial. So the ARRIVE trial, some of you were talking about this the other day, and I'm going to show you a couple more slides about that. So this was a study that was looking at, hey, if we induce first time single babies, only one baby, not twins, at 39 weeks, are we going to have better outcomes for moms and babies? Let's see. And so their data came back in, and that's what we're going to cover in just a minute. And question from Kirby, BMI at the time of conception or birth? At the time of conception, I'm pretty sure, I'm going to double check that, but I'm pretty sure it's at conception. Okay, the next one, wanting a specific provider. And that was the story that I, kind of shared last night about providers saying, hey, you're 39 weeks. I am on call on Wednesday. Let's get you in for an induction since I'm on call and we have a relationship. You don't know the rest of my practice. And that would be an elective induction. The next one, wanting a specific due date. So some people want a specific due date for whatever reason, whether they have family coming in town to help take care of the baby, they have a partner that can get off work, they have, they want to have the baby on the 8th of the month and not the 10th because of, whatever reason, that is considered an elective induction. And then that fourth one is past your due date, but not over 42 weeks. So between the 39 weeks and 42 weeks, if you have a provider that says you are 40 weeks and 6 days, I recommend an induction. That is an elective induction. Now, it doesn't feel like an elective induction. So this, let's talk about the arrived trial, and then I want to talk through that scenario. Okay, because, over here, the arrived trial. So if anyone follows Rebecca Decker at Evidence-Based Birth, great website. She's awesome. I've been friends with her for years. She says the elective induction at 39 weeks does not make a difference in the rate of death or serious complications for babies. For mothers, induction at 39 weeks was linked to a small decrease in the rate of cesarean compared to those assigned to wait for labor. So 19% cesarean versus 22% cesarean. So what does that really mean? Like putting that all together, what does that mean? So what that means is induction at 39 weeks lowers a risk of C-section by about, on average, 16%. Now, here's the next part that I think is pretty eye-opening. So if we say, oh, maybe I should get induced at 39 weeks because it lowers my risk of cesarean. Well, maybe we should also consider using a doula because doulas lower our risk by 25%. Or maybe we should consider instead going into labor and choosing intermittent monitoring because that lowers our risk by 39%. Or the bottom one, which is everybody here in this class is learning about, if you use comfort measures like movement, have we talked about movement, and hydrotherapy, going to talk about today, that lowers your risk by 16%. So a lot of things that we can choose lower our risk of cesarean birth, not just the induction choice. Does that make sense? And let me know if it's like, wow, because I think it's pretty wow. I think it's like, why don't we talk about some of these other things? If we know, if research tells us that comfort measures, moving around, hydrotherapy lowers risk by 16%, why is that not the talk of every doctor out there that says, like, get out of the bed. Let's start moving around. Let's get you in the shower. Let's get you in the tub because it lowers cesarean. But unfortunately, and I'm editorializing a little bit, but it's, from my experience and what I have seen is the medical profession has not adopted some of these non-medical ideas, even though they're so effective and huge and important and beneficial, and yet they're just ignored. And the things that are like medical and I can control them with medicine sometimes is elevated to important. Okay, got a little preachy there. My apologies. Okay, let me look at, is it Maria? AMA does not seem, so advanced maternal age is AMA, does not seem to me medically indicated. My provider told me induction at my 8-week appointment for 40 weeks, scheduled now for that. I and baby have no other medical problems. So Maria, let me know if I'm pronouncing that right or write the phonetic spelling. I'm going to keep this up for a second because I think talking through your situation is exactly what Kirby, was it Kirby? I think this is sort of a scenario that you were asking about. Like, what if your provider is suggesting something is medically indicated, you don't feel that that seems the way, what options do you have working through? So first of all, I'm sorry, Maria. Oh, thank you, Maria. That makes sense, Maria. Okay. First of all, there might be options that you have. Okay. And let me just first say that I'm sorry that you're in a position where you have to think through these options. But I also want to acknowledge the fact that this is very common. So you are faced with something that a lot of people have been faced with. So now let's talk it through. What does that look like? Well, first of all, American College of OBGYNs said that you have your choice matters. So inducing for advanced maternal age is very much a sort of provider by provider difference. So though your provider might say it's medically indicated, you could possibly go to another provider that has a different mindset on that. So that could be an option for you of changing providers, changing hospitals, facilities that work with more AMA patients, that are more, give more time past 40 weeks to induce. And I think, though you might not have an option, because I know as far as our health insurance, where we live, we might not have options to change providers. The other thing that I would encourage you to do, if you're thinking about it, is talk to your provider about, what are the benefits and what are the risks, and and I'm going to talk through this scenario coming up that's frustrating. And I'm going to kind of circle back to your example, Maria. Okay. Because this is a great example. Now, Kirby, you had asked, you said, where did you say it? I saw it. You were asking for more about when it's medically indicated and there's no other option. So if it is clearly medically indicated, preeclampsia, we need to start your baby now. You don't have a lot of options that you could ask to wait, but for a truly medically indicated induction, they are going to strongly recommend that you go and get induced. I mean, because of your health, because of baby's health. Again, those are the big ones, cholestasis, your membranes ruptured, your preeclampsia. There's not a ton on that list, really, that are medically indicated. I know I had it in small font, but those blue ones were the kind of provider by provider situations. So let me know if that makes sense. Okay. Yes. Well, you know what, Kirby, and that, you said that you don't want, or you cannot imagine sounds like having the Foley catheter. And that is totally your choice. That your next, like you might say, the only options that I am comfortable with for an induction is I'm comfortable with Cytotec and I'm comfortable with Pitocin. And that's what I'm comfortable with. And that's what I'll agree with. And so you can say, I'm not doing the Foley catheter. And that's not necessary. So because there are other options for induction, you do have options for you might have options if you say, nope, too much trauma that could bring up, I'm not going to do that. Okay. Let's see. I'm going back. I'm turning back because I think I missed a question. Oh, okay. Patty said, if inductions can sometimes take multiple days, isn't the provider is the only available this day reason not that great? Thank you. Thank you, Patty. I have had this conversation so many times. I have had this conversation with so many people to say, hello, It doesn't matter. And sometimes they'll say, well, I'm on call Wednesday. So let's have you come in Tuesday night to get the Cytotec. And then hopefully you'll have the baby on Wednesday. And I have worked with clients that come, the shifts come and go, and they don't even get to see their provider, or their provider doesn't even come and check on them. It is heartbreaking. It is not okay. Heartbreaking. Because some providers, have not all, this is not all, but sometimes you see that, where, they, just try to kind of influence, like, well, it's going to be me. And, and then it ends up not being. I don't like that. That is, not okay. Okay. I am looking through questions. I don't see any cues, so I am going to let me know if you guys have a question. Turn back on my slides. Okay. Let's see. So the ARRIVE trial. The ARRIVE trial is like, that's kind of crazy, right? Kind of, hold on. Having a tech issue. Here we go. Over the age of 35. Let's talk about that one next. Because Maria was talking about that. So this is another quote from Rebecca Decker, who studies all of the research and has given the statement, there's no consensus among researchers and obstetrical midwifery organizations on the best way to care for a person at the end of pregnancy when they are 35 or older. And, this is one benefit of being a doula and being able to work with clients that are giving birth in all sorts of healthcare settings. And let's just say Atlanta, for example, since I spent so many years there. You could be at one hospital with one practice that had a strict over the age of 35, 40 weeks induction deadline. And you could cross the city to another hospital that was doing a 41 plus 3 week for over the age of 35. And I mean, it's just based on the provider, because you're the same person and you're getting getting one recommendation and another in the same city. So there is no consensus. So this is a confusing one. Yes. Now, let me see my next slide. Oops. Okay. So, and then we're going to talk about some real life scenarios. I cannot believe it's 53 minutes into this class. It's so big. So two that I just want to put out there, just so you know, low amniotic fluid is not supported by evidence. So that would be if you had a late term ultrasound, say in your 38 or 39 weeks, and your provider says, oh, your amniotic fluid is low, we recommend an induction. That's not medically indicated. Okay. The other one is a suspected big baby, but if they're guessing the baby to be like 9 pounds, not supported by evidence, not better outcomes for babies. Okay. Not medically indicated. Okay. I want to pull up something real quick. Give me a second. I'm going to let you guys add any, because it has to do with COVID and what's going on with the healthcare shortages that we see right now in labor and delivery. And we're seeing that all over. It kind of comes and goes depending upon how busy the hospital is, how staffed the hospital is. But yes, Patty, I just caught that. Ooh, you said sister was induced because of low fluid. Yeah, it happens, but it's not medically necessary. Okay, so here's the situation right now at some hospitals, could be affecting your area as well, that there are nursing shortages. And when there are nursing shortages, it's already hard to really staff labor and delivery. You never know how many people are going to come in at any time in labor. So a lot of times they've had people like They call extra nurses in. They send nurses home when people aren't there. They have to keep people in triage for longer than possible because they don't have any rooms in labor and delivery. There's lots of kind of shifting around. Well, where we have seen it as doulas, especially like crystal clear, is during the shortages that are happening with the pandemics. So I'm going to read something out to you, that a scenario that has happened that I saw on a message board, and I was like, oh my gosh, this is so real. So the doctor, this is a person saying that their doctor highly recommend an induction by Monday at the latest. Okay. So I don't know the reason. Maybe it was because of, like, let's say age, right? Maybe Maria, maybe your scenario. Doctor recommends an induction by Monday at the latest. Scheduled to come in at 8 a.m. And then the schedule was changed to 10 a.m. Then the schedule was changed to 8 p.m. This is all on the day of Monday. Then they say, we'll call you in the next morning because there's no room at the hospital. So then calls at 10 o'clock and says that they aren't sure when they'll be able to have this mom come in for an induction because of the high surge of COVID patients being admitted. And they find out, they're told by the scheduler that they're canceling all elective inductions. So here's the story. This is a scenario that I have seen time and again, doulas have seen time and again, and that is where your provider tells you you have to be induced because of whatever reason and schedules a time for it, and then your induction gets bumped because they don't have space. So take a pause and let me know in the chat. Does that seem like it's medically necessary? Is it medically necessary if they can keep rescheduling you for an induction? What do you think? Okay. What are we talking about over here? Kirby said, why won't they let us get the IV in the elbow area placed in labor? I don't know about an elbow. So you can usually have your IV placed anywhere from your hand. This is a very popular place right here, your wrist, your forearm. They try not to do it here right on your wrist, so it's hard to bend. And the hand usually hurts. So most people, if they get the port, they get it right here. Yes. Arm, not hand. Jay said, where do they put your IV if not the elbow area inside the arm? Oh, you're talking about here, like this area. So they don't usually put the IV port there. They usually put it on this forearm, and it kind of stays out of the way there. Yeah. Okay. Lots of IV talk. You guys answered each other. I love it. Yes. So it's not medically necessary, right? Yes, Melissa, you are right. Let me get to your question. Patty says, how does staffing issue affect you if you come in spontaneously at a busy time? Yeah, if you come in spontaneously at a busy time and there's a staff issue, they can be really short-staffed, and it can feel like you don't see your nurse much. And it can also be a little bit worrisome. Like, it's been hours and I haven't had a nurse come. So that can affect you too. Yes, you are right, Melissa. Thank you for this correction. It can be medically necessary, but not an emergency. Yes, that is true. But with labor and birth, usually if it's medically necessary, there's a short window that it needs to be done. So yeah, that's a good distinction though. Yes. Calculated risk. Yes, absolutely. They're weighing their risk. Okay. But what what is really hard to see and experience is someone who has been convinced that there is a date that their doctor does not want to go past for whatever reason. And then they end up going past it, because there's no space for them at the hospital or staff or whatever. And so it's kind of like, it's very scary for you if you are told that you need to have your baby be in labor by a certain day, and then they don't let you be in labor by that day. And then you start wondering, like, well, was it really necessary in the first place? Does that make sense? I hope I'm explaining that right. Okay, I'm looking for questions. What happens if your vein blows getting Pitocin? They start a new IV in a new vein. Yep. But doesn't necessarily, it can happen. Yes, they might have to transfer to another hospital or that kind of thing. How often do you see your nurse or doctor? You usually see your nurse at least once an hour for vital signs. And you might see them more than that. They're very much in and out. They don't stay in labor with you. Doctors usually do their rounds, and midwives, where they come several times during the day to check on their patients that are in labor. Usually people see their doctor about every 3 to 7-ish hours. It could be a while. Is there a chance of birthing in the lobby or triage if short-staffed? Yes, more about triage than lobby. And yes, definitely triage babies happen. Yes, Christy's story. Oh, Kayla said she birthed in triage. Yep. Fast babies can be birthed in triage. Yeah. Yes. So Melissa was on magnesium. So Melissa, when you have a specific health condition and you are at a higher risk, definitely they're going to be they're going to be watching better. Did I get your question, Jay? I saw the question. Okay. Patty said, I know this isn't where you're going with this, but it makes sense to me that you should preemptively schedule induction a few days earlier just in case you're bumped. This is definitely not where I'm going with it. I personally, I am a true believer in letting the labor start on its own. There's so much value to it that I definitely am not suggesting that in this story. My point of sharing that is to let you know that, that's been happening, and it's also super hard. And the reason it's hard is if you are in this gray area where you are told by your provider that your induction was necessary, and then you find out that it's actually considered elective. That's the part that I want to kind of highlight. Yeah. Okay. What else? Let me look at my notes and you guys do questions. Oh, did everyone watch? I have a homework check-in. Did anyone watch the Bishop's score video that was on the homework for last night? So I know I didn't have the right homework link in for tonight, but last night there's a video that I made it's called the Bishop score. And it's where your provider does a vaginal exam and basically scores how likely it is that if they do an induction, that it will be successful. The likelihood of success of an induction. Oh, good. We see some Bishop scores. Awesome. Oh, cool. Kayla, thank you for that. I was actually thinking about doing some more videos, breaking it down in the notebook. So I might do that. Okay, great. So Bishop score, I think, is so, it's really a good piece of information to have if you are wanting to know about induction, and if your provider is suggesting it or recommending it, like, hey, you're 40 weeks, I recommend an induction, and you say, well, what's my Bishop score? And if your Bishop score is like 3, you can have that conversation and say, well, it doesn't sound like my induction is going to be successful. Can I have a couple more days, or is that an option that you would recommend? So it's a good piece of information to have. This is funny, Anne. You totally have an engineer's style of writing. Yes, I do. Yeah, I've never thought about it. Bishop's score video was great. Although I kept thinking of my husband's grandma who had 13 kids. Oh my gosh, what would her Bishop score be? What? That's funny. Previous kids. Yep. The more kids you have, it changes the score for sure. Okay. Let's see. Question. Kirby says, is a C-section ever an alternative to an induction? Absolutely. Yes, it is. It is. You could recommend, or you could opt for a scheduled cesarean instead of a scheduled induction. We're going to talk about that during our cesarean birth our cesarean birth class, which is class 11. So we have pushing tomorrow, then cesarean birth, then the baby, then our pain management layering, and then we have our quiz. Oh my gosh, let's talk about hydrotherapy, guys. If I missed anything, because it was a lot today, and you have questions, bring them to class tomorrow, send me an email, comment on a video. I try to answer all of my video comments, but I know that I missed one. Okay, so let's talk about hydrotherapy.
Just a quick reminder, if you like the video, give it a like. Thank you. It really helps. It makes the stream bigger and more people can see it and more people can get help, which is better.
Thank you, Nathan.
So please like
it. Seriously. Sorry. I don't even know what to say. I can't, yell at a child while I'm live streaming, but he is trying to be helpful. Smash the like button, according to Nathan. That is, I have no idea. I put him in charge of dinner. He should be working on the enchiladas in the oven, but we'll get there. Okay. Yes, Nathan. Funny fact about Nathan. I will tell one Nathan moment. He's my fourth child, and he was my biggest, and he was over 11 pounds. Crazy. That's the story for another day. Maybe I'll make a video about it. Okay. Hydrotherapy. I cannot skip this because I'm a huge believer in hydrotherapy. It is, for me, like, do you ever have, when you go to a new city or you do some traveling and you have like a checklist of things you must see, right? You have must see moments. You want to see the Eiffel Tower in Paris. I'm just picking Paris for whatever reason. When you go to Paris, you want to go to a cafe. You want to experience the Eiffel Tower. You want to eat some cheese. A bucket list, right? I really would love for everybody to put hydrotherapy on their bucket list, because I feel like it's that good that sometimes people in labor don't want to do it. So there's a couple things with hydrotherapy. We've got the tub and the shower. I'm going to start talking about the shower because the shower is the one that's usually most accessible to everyone. I love you guys are talking about Nathan, algorithm boosting hype man. He is almost 12. Melissa had a really good question. Did I miss a question? Oh, you never talked about going past dates. I thought I did. Okay. So let me pause on hydrotherapy, because going past dates that's the elective induction. That's elective induction. So if you go, until you go past 42. So past 42 is medically indicated, but from 39 to 42 is elective induction. And that's the one that's most common that people have, conversations with their healthcare provider about. Awesome. Okay. Whew. here we are. Okay, let's talk about Inca. You're nice. Let him speak. I think I was worried that he was going to ask me about the enchiladas. And so I seriously, I left him notes on what to do for dinner. And I thought he was going to start talking about the enchiladas. And so that's why I was kind of pushing him out, though. Now I'm talking about the enchiladas. Okay. Risk of going past 42 weeks. So after 42 weeks, we see a marked increase in the incidence of stillbirth, and they think it's likely due to placental issues. So there is a slight increase that goes up after 40 weeks, and then we see more of a jump after 42. So 42 is really where we see more of a jump, and that's the risk of going past. Okay, so I'm talking about the shower, and I am going to block. I was going to block another bot. Like, why? Right? Why? Okay. So, hydrotherapy, the shower. The shower I like to talk about first because it's accessible to everybody. Basically, pretty much everybody has a shower in their home, and almost all healthcare where you're going to give birth have showers. Not all have tubs, but almost 100% have showers. Okay. So that is why I like to start with that. The shower is an excellent place for labor. It has so many things going for it. It has warmth. It has a white noise of the water hitting you. It has the comfort of just water and the comfort that we usually feel from being warm. And it is private, where we don't have people staring at us. We're in this cave-like environment of the shower. So I am a huge believer that put that on your birth bucket list, that you want to spend some time in the shower. Tell your partner what your bucket list is. Tell your support team, whoever's going to be there, what your bucket list is, because for whatever reason, I have experienced often enough, people in labor have a hard time kind of getting past the effort that it takes to get into a shower. So sometimes I've had people say, oh, I don't want to get in the shower. Like, I'm going to have to get undressed and get wet, and then I have to dry off and then get dressed again. And it feels like a big effort. And I want you to get past that and get into the shower, because getting into the shower is usually like magical, and trying to stay in there for seriously as long as possible. You might have to come out to get monitored, or if you're feeling waterlogged, but really when I say a shower, it's not like a 15-minute shower. It's like a shower for 45 minutes. Okay. I am looking at, am I missing anything? Okay. Yes, Melissa. So Melissa, I think that is a conversation with your healthcare provider. Again, that's why it should be a conversation, right? Diana, water birth at North Fulton. I have absolutely spent so much time at North Fulton. Man, I have so many memories over there. So cool. I'd love to know who your midwife is. That's cool. Kirby, can you bring a birth ball into shower? Yes, you can. Just don't cover the drain with the birth ball. Who did that? Me, this doula. Yes, one of my not so fine moments when I realized that I had just flooded an entire hospital room at the Atlanta Medical Center Hospital, and because we kept the birth ball over the drain. I mean, so embarrassing, but yes, you can bring one in the shower, and I love it. It's great. I like to put a towel over it, so it gives you some like friction to sit on, and also you can sit on a towel and not the plastic. So great. Cindy, boom, added shower to her birth plan form. Love it. Okay. And then let's talk about we're talking about, yeah. I haven't thought about that memory of the flooding of the bathroom in so long. And I was an experienced doula and I felt like just the biggest dummy. It was bad. Okay, so let's talk. Do hospital showers run out of hot water? No, they don't. It's amazing. And if you feel bad about using a lot of water on this day, just conserve water for the rest of your life, because this is a big deal and can be excellent, an excellent layer. And let's just talk about the layer of that, of coping in the shower. You've got the peaceful environment because you're going to have the lights off in there, and you're going to have your twinkle lights, your fairy lights, your battery operated candles. You're going to have your Bluetooth speaker or your phone that's playing some lovely music. You are going to be leaning up against the wall and letting that water hit your back, so you're in a great forward lean position. You're going to be nice and loose. You're checking in with your butt. You are lowering your jaw. You're breathing in nice and full. And then if contractions are strong enough, you're doing some nice vocalization. Ooh. And if they're really strong, we're doing horse lips, right? And that whole time, what are we doing? Each time the contraction comes, we're doing our go-to visualization. So we have just built this gorgeous layer cake of coping strategies, including that water. It is awesome. Okay, let me know who has a cake emoji for me? Who's the first to put a layer cake emoji in our chat? And Kayla, I love this idea. Lotion for an after shower massage. Oh my gosh, I love it. That is how someone in labor should be treated. Jay's going to be in the birthing party in the shower for hours. Yeah. How long does showering for that long dry your skin? Yeah, it could, but yeah. Oh, we've got some cake emojis. I love it. Okay, good. With all they're going to charge us, I wouldn't feel that bad. That's right. That's so good. Oh, yes, Christy. I love that you're going to have Melissa there. That's so cool. Very cool. Yes. We have known each other for a long time. Yeah, I've worked with her in her earlier doula years. I love that there are a lot of people with doulas in the chat. Okay. I want some cake too. There's so many different cake emojis. Bathtub. Now, in the video and the homework, you guys are going to watch about using the tub in labor, so I'm not going to go too far into it. If you get into a tub too early, it slows it down. We like that in early labor because then it helps us rest. In active labor, a tub is not going to slow our contractions down. And a lot of doulas and midwives call a deep tub an aquadural, the aquadural, because it can totally relieve some of that pressure, some of that contraction contraction pain. And so that is what makes water birth so lovely, is that it really can relieve the pressure, relieve the pain at such a critical moment, usually that active labor through transition and then into birth. So check out those, but I want you to put hydrotherapy on your bucket list. Okay. Let's see. Quick question from Miranda. Silly question, but can I push out the baby in the shower or do I have to be on the bed? So Miranda, you technically, like your body is able to push a baby out in the shower. Yes. And have I seen one before? Absolutely. You have to have a provider that will support it. So if you are working with a midwife at a birth center, or you're working with a midwife or a place that does water birth or whatever, you're definitely more likely to have this happen. But if you are at a hospital that doesn't support that kind of birth, then probably will have to birth in the bed. But technically you can. I mean, I've had clients give birth in the shower, in the tub, standing up, hands and knees, all different positions can be made. Okay, guys, we're going to do our 30 seconds because I know it's getting kind of late. Elizabeth said, do they keep the tub temp warm? So in like a standard hospital tub, usually we just drain it and kind of keep filling it, adding hot water to it, adding hot water to it. That's what I do. If you're in a water birth tub, we also are managing the water. I say doulas and nurses, but those stay warm because they have a lot of water in them pretty well. Okay. Kirby says, can you just say no when they tell you get out of the shower and move to the bed? What will they do? Carry me. Yeah. I mean, yes, that is true. The only thing about that, Kirby, and I'm going to reiterate this tomorrow when we talk about pushing, is that you are right. If you say, no, I'm birthing here in the shower, they're not going to, come grab you, put you over the shoulder, whatever. But if they are unskilled at catching the baby when you're in the shower, that could increase risk of tearing because they're not going to be able to support your perineum, or could increase risk of, them not like properly. I mean, they'll be able to catch the baby, but it's just, if you put someone in an environment that's really unfamiliar, they're not necessarily doing their best work. We're going to talk about this again tomorrow when we talk about pushing. So it's something to kind of think about. Once in active labor, they're too soon for getting in the tub? Not really. No, once you are about 6 centimeters, contractions are coming along steady, there's really not a reason. No, unless your provider, like fetal heart tones being concerning or something like that. Any concerns with the baby or your health, they might not. But other than that, if everyone's healthy. Okay, let's do our 30 seconds, guys. So in our 30 seconds, I want you to think through that scenario that we were talking about, that I just layer caked it up, and visualize, use your visualization. I want another practice of the visualization and as many layers as you can. Okay. Hello, I just added it here to our birth toolbox. We've got hydrotherapy right after our peaceful birthing environment. Whew, we did it, guys. Class 9. I know it's a lot to take. It's a lot of questions. And sometimes I feel like, are we rushing through this topic? And that's why I made it into the 2 days of the induction. Hopefully you feel like you have enough information. And then if, at any time, you can always contact me as well. I am super excited to offer this new course on the 15th. Hope you can join me if you feel like it's something that you'll benefit from and are really curious and feel like mindset is going to be a powerful way for you to deal with contractions, or the class on January 26th. Okay, so tomorrow is pushing, and I cannot wait to see you all tomorrow. Thank you so much for hanging out with me today, for being such engaged people. Thanks for understanding when we had a photo bomb, a YouTube live stream bomb. My video bomb was a lot better than the bots that we had to deal with, because those weren't fun. But I appreciate your time, whether you're watching live every day or you're watching in the replay. You are putting a lot of effort into this class, and it is going to make a big difference for your birth. So thank you for being here, and I look forward to our big pushing class tomorrow. I'm going to see you over in our other room, and we will get it done. Talk to you later. Bye, guys.